Thank you so much, and hello everybody. I shall be covering how to avoid and manage missed clinic visits with injectable antiretrovirals. These are my disclosures. So I'm going to talk about the importance of adherence, managing missed visits, avoiding missed visits, and finishing with some closing thoughts. Let's start with the importance of adherence. Now, we know all about adherence in antiretroviral therapy. We know in any condition that if you don't take the medication, it won't work. But what's unique about HIV treatment is you don't just lose condition control with viral rebound, you also risk development of resistance and you risk onward transmission, which is unique for a long-term condition. For prevention, if adherence is an issue, then there, of course, the risk is HIV acquisition, and that's not reversible. So it's kind of obvious that adherence is important. But I think despite it being obvious, it's really well described and covered in this really good review or editorial that was published in 2022, looking at cabotegravir for prevention. And here we know cabotegravir PrEP is more effective than oral PrEP. We'll look at that next. But here the authors remind us that the advantage of bypassing the need for daily adherence by using injectable PrEP can't be realised if people don't come back for their injections. So that is, of course, critical. And here is that data. This is HPTN-083 in men who have sex with men and transgender women at risk of HIV. Similar, indeed even better results relatively in HPTN-084 for cisgender women at risk of HIV. But in both the studies, injectables superior to orals for HIV prevention. And that was driven by the fact that adherence was much higher. So adherence rates much higher on injections. If you look at the people who are able to take oral ART, it works very well. It's just that injectables support adherence in a way that orals don't. But if you look at the people who acquired HIV, for the oral PrEP, tenofovir, disoproxil and emtricitabine, adherence was critical. Only 2 of the 39 people who acquired HIV had optimal adherence. So but the majority of HIV acquisitions were amongst people who weren't taking the oral PrEP as directed. Adherence is crucial. For injectables, adherence is still important, but actually here, although it's a smaller number, because it's more effective, the proportion of people who acquired HIV with on-time drug was slightly higher. So 4 of the 12 who acquired HIV had their injections on time with good drug levels. Now, still most, 8 of the 12, had missed visits, but 4 didn't. So adherence is still very important. But here, adherence isn't the only explanation for why people acquire HIV on cabotegravir, and that's something I think still isn't fully understood. Now, when we look at injectables for treatment, however, adherence to the injectable visits or lack of adherence isn't the explanation for viral rebound. So all the people who got viral rebound in the trials, in fact, I think pretty much everyone in the trials anyhow, had their injections on time. And we don't yet know from real-world evidence what will the impact of missed doses be. Undoubtedly, if you miss doses, there's going to be a higher risk of viral rebound, but I don't think we yet really understand what degree of missed doses is going to be best predictive of viral rebound. It may differ very much from one person to another. So I think a lot of uncertainty still. So how do you manage missed visits? Now, the target date is the date in any given month that an injectable should be given, whether that's for treatment or prevention. So rather than counting 8 weeks specifically, which might fall on a different date in a given month, aim for a single date. Here the example is the 15th. Aim for the 15th of the month when the injection's due, and you can have the injection up to 7 days before or up to 7 days afterwards. And that 7-day window is based on pharmacokinetic data, but also PK simulations. If you can't attend for an injection, then you can apply oral bridging, and about switching to oral therapy to cover that period when the injectable hasn't been given. And it's not about pharmacokinetics. I think when I first heard about oral bridging, I assumed it was about maintaining cabotegravir and rilpivirine levels. Well, it is if you're taking cab and rilpivirine orally, but it could be any antiretroviral regimen because it's about maintaining viral suppression. As long as it's an effective option, any option can be used for oral bridging. Now, this is looking specifically at oral bridging for cabotegravir. I'm going to focus on the right because 8 weekly cabotegravir is what's been approved, not yet in England, but that's what's been approved for PrEP. And 2 monthly rilpivirine is all we have available in Europe. Although monthly and 2 monthly are both licensed, 2 monthly is what we have available. And indeed, obviously and understandably, that's what most people prefer. So let's look at the right. It's looking at cabotegravir concentrations with injections, and you can see the impact of oral bridging. Without oral bridging, there's a risk that the cab concentrations will fall below target concentrations for many people, but that oral bridging maintains that drug concentration. And there are similar graphs for rilpivirine. So imagine you've missed an injection, you've had your oral bridging. Now, importantly to point out, of course, you're only going to access oral bridging if you have access to oral therapy. So that means either planning in advance. So if somebody on injections knows they're going to be away and can't attend for their visit, that you can proactively prescribe that oral bridge in advance until they're able to come back to clinic for the injection. If, of course, you don't anticipate that and somebody misses an appointment, then they're not necessarily going to have access to oral bridging. So thinking about how that will work is really critical. And I do think having either immediate access to oral bridging at home or at least a mechanism to get it quickly, because if you've not been able to get to clinic for that injection, how are you going to collect your oral therapy? We might need to think about broader ways to access it if bridging's required. Anyhow, you're restarting your injections. How do you restart them? And that's all down to when was the injection missed. If it was less than a month ago, you can go back to your 2 monthly schedule. If it was more than a month ago that the injection was due, you need to start again. You need to have that kind of loading of 2 injections 1 month apart. And again, whether this is for treatment or prevention, first 2 doses a month apart, and then you go to every 2 months as before. Now, of course, when we think about stopping long-acting antiretrovirals, well, it's just simply not recommended. So if anyone stops injectable antiretrovirals, we want them to go on to oral antiretroviral therapy instead, because we don't recommend treatment interruption outside, of course, carefully controlled trials looking at cure strategies. But for prevention, it's standard, it's normal, it's good indeed to be able to dip in and out of using PrEP according to your risk of acquiring HIV. So we need to be very careful about how we counsel people. If they stop oral PrEP, the drugs will disappear very quickly. If they stop long-acting PrEP, it's going to take much, much longer. Because from a pharmacokinetic perspective, stopping long-acting PrEP or cabotegravir takes a long time. So again, there's a few sources of data here, but I'm going to quote this very good paper highlighted earlier. In HPTN 077, which is a phase 2 study of cab PrEP, 13% and 42% of cisgender men and women respectively had detectable cab concentrations 76 weeks after their last injection. Now, whether all of that detectable drug was at a high enough level to drive resistance is less clear, and it may be that the drug drops to a level that's still detectable, but not high enough to push integrase resistance, but we don't really know. And what that translates to is we need to be thinking about this for at least a year after stopping that cab. Now, reassuringly, albeit with very small numbers, HPTN 083, the study I showed you earlier, there were 3 people who acquired HIV during that tail phase, and none of them had integrase resistance. Reassuring, but as the authors say, we're going to need more data from trials and real-world cohorts to fully understand whether there is a risk of driving integrase resistance in that tail phase, because 3 cases clearly isn't enough. Now, how do you manage stopping injectable PrEP? There's some clear advice from the US guidance here that people should be informed of what the risks are, including developing drug-resistant HIV. And generally, it's recommended that if there is any possibility you might be exposed to HIV in the 12 months after stopping the injection, that you should switch to oral PrEP. Now, clearly, if you're at risk of ongoing HIV acquisition, you should probably be on PrEP anyway. You should probably stay on that oral PrEP, but certainly covering that tail, unless there's zero risk of HIV acquisition, with 12 months of oral PrEP is what's recommended. That's how you manage missed visits. How do you avoid them? Because, of course, prevention is better than cure. And here again, I'm stating the obvious, and I've touched on this really already. When we think about oral ART, treatment or prevention, we've got a lot of information and a lot of advice we give about how to take that medication every day or whichever way it's indicated. But of course, for injections, because at the moment they are only administered by healthcare professionals at clinic visits, it's not about adherence. What people do in between the clinic visits is irrelevant. It's about attendance. I know that feels obvious, but they're two different things. And some of the evidence around adherence and taking meds every day isn't necessarily going to be the right evidence for making sure people come to clinic on time. And actually, there is already, not just for HIV, for all healthcare settings and conditions, a lot of evidence about interventions to support coming for clinic visits. But the barriers and therefore the solutions are going to vary a lot in different settings and different populations. So in a way, we should stop the talk here and you should go and research what evidence is there that's applicable to the people you see to support them to attend clinic. This is some data from the UK, a brilliant study called REACH. This is in the context of HIV treatment. And this is some of the work from the qualitative element, asking people what would support them to attend. And you can see it there. I won't go through every one, but reminders and a pre-agreed action. What do you want the clinic to do if you don't attend are just a couple of the solutions. Now, I like inventing new concepts, and my new concept for this talk is the 3 E's: education, efficiency, and empowerment. So for education, it's not enough for a healthcare professional to say what someone must do. You must come to clinic on the 15th, 7 days before or 7 days after is okay, but that's what you must do. I think it's important to explain why someone needs to, explaining drug levels, explaining the consequences, drawing pictures. I often have scribbled pictures of graphs and drugs in my clinic room where I've used drawing to illustrate a point. But making sure someone understands why it's important to attend, I think, is much more useful than simply telling them they must be there. Efficiency. Now, if someone has had a very inefficient experience, they've waited 90 minutes in the clinic, their prescription wasn't ready, had to find someone to prescribe it, all the obvious things. If it was a slow, negative experience, the next time when they're busy at work, they may think, I don't have time, I'll have to do it tomorrow, I'll have to do it next week, and suddenly a visit has been missed. So I think making appointment duration, but also the timings, as flexible and convenient as possible is important, including weekends and evenings, and making sure the process for prescribing and giving the injection is as seamless as possible. Empowerment, giving people the option to schedule and reschedule appointments in their way at the right time. Imagine you have an appointment tomorrow. At midnight, you remember you have another meeting and you can't go to clinic. Now, is it better to sit on the phone the next morning trying to contact the clinic, or is it better to be able there and then to go online and reschedule your appointment as soon as you realise? I think that's obvious. It's not the right option for everybody, but empowering people to choose what's best for them is helpful. Similarly, empowering people to employ oral bridging when they need to, I do think it's important. I do think we need to think about how we make oral bridging more easily accessible. Now, at the moment, oral bridging is considered exceptional, but I think in the future, I imagine we'll become more relaxed at people moving in between long-acting and oral options to fit best with them. Because I don't understand why once you're on injectables, oral should be an exception and actually not part of a dynamic antiretroviral journey. My closing thoughts, and I think what we must remember, we have a saying, and I hope that saying is a more global one, but it's a saying that you cannot put a square peg in a round hole. And we must remember that we've been using oral antiretrovirals for a long, long time, and our services have shaped around oral antiretrovirals. But if oral antiretrovirals are a round peg and our services are therefore a round hole, we need to acknowledge that long-acting antiretroviral therapy is a square peg, and we may need to reshape our services to best support people to access it. I shall finish there. Thank you for listening. There are various ways to contact me should you want to. I'm looking forward to joining you for some questions. Thank you very much.